Hello, Isabel.
Olá, Isabel, parece que o som não está a funcionar. For sound. For sound. You're there. Okay. Victory. Okay. Excellent.
I'm so sorry for the panic.
No, that's all right.
I received those programs for the board meetings and group meetings, etc. And it looked to me that no webinar was happening, etc. until 2 days ago. That's fine, but we always manage.
It's sorted. That's all that matters now.
And yesterday I was in clinic all day, and I have the habit of not checking emails while I'm seeing patients.
Well, quite sensible.
It's very hard. I know people who are always checking emails at the same time. I have that. I try to focus on what I'm doing.
Yeah.
So it caused also some difficulty, but now it's done.
Very well. So do you want to try to screen share? I will stop my screen share and you can try to put your screen share up. Okay. Otherwise, I can share your PowerPoint. Yes. I'm ready for that.
I'm just going now and minimized, and let me just screen share screen better, and I have it here.
Yeah, it's perfect.
Is it?
Yeah.
Good. So I'll put in presentation. Is it as a presentation? Doesn't seem to be. Okay.
Yes. If you want to leave it like that, we can leave it like that. And
absolutely, I'm fine with it because it's just a few minutes, isn't it?
Yeah, it's so.
No, I'm going to move my mobiles from here, give them to my husband so he can look after them while I present it. I don't want to be interrupted. And if I put them in flight mode, I may forget after the meeting. And
to put it back here.
So it's better I give him and say something if someone calls. Anyway.
Yeah. Okay, no worries.
Zinga?
She's fine, thank you. Doing something else, I don't know what.
In the other meetings.
Yes, yes.
Okay.
Okay, so we have some time. We have 59 registered attendance, but it's still early, so
yes, it is. It is. I just made sure that I was in time and things were fine. Let's just move to give this to my husband. Okay. I have my tea, I have everything here, but I want to get rid of my mobiles. Just a second.
Herman, I see that you have again your raised hand. Do you want to say anything?
Can you hear me?
Yes. It's you, Annelies Herman, but Herman is a bit.
Herman, I've got a really complicated question to ask you. No, I'm gonna go back to the institute to do the genetics meeting because everybody's home here. Do you mind if I log off and I hop back there, because I think I'll be better in my office than here?
That's not a problem.
Okay.
In fact, I should be doing something at 4:30 because I forgot to cancel it. So I told Giselle that I wouldn't attend. So everything will be fine.
Oh gosh, what a crazy day. It's been one of those days. Oh gosh. Okay. So basically I'm gonna do the PAB, the genetics tonight, and the PAB, and I'll log on as if I'm Teresina. So I'll just warn her not to be worried when she sees another Teresina connected.
Okay, no worries. Bye now.
All right. Take care. Bye.
Bye. So you tried to, but you received some email inviting you for the meeting of the neuromuscular junction. Is that right?
Yes, I received. It was combined, combined with others, and when I tried to register, didn't allow me to register. And then I asked, because I thought it was something to attend, and I was told no, it's only for a strict number of people. And then I thought, okay, so it's something different. I'm not required.
Yeah, that's for the development of pediatric and
guidelines for
treatment guidelines. And Jackie Palace is leading on that. I don't know. I thought why that happened as well.
Because it was in the afternoon. I thought my webinar was somehow integrated in neuromuscular junction work group or something. It was probably my misunderstanding. I don't know, but it's solved.
If it's solved, that's what matters.
Yes, absolutely. No. And tomorrow I will attend the board meeting. Ask to attend. Ask someone from Oxford.
I'm sure you'll be admitted.
I registered already. I was able.
Yes, no worries about that. Okay.
These things.
So in the beginning, I'll do a short presentation. So I'll say that you're a senior clinical research fellow and
now an associate professor.
Associate professor, okay.
You know, I'm not very good on updating my profiles in my websites and this and that. So university website and the MyAware website still have me
as clinical research fellow, So associate professor and honorary consultant neurologist. Yes, and that you're interested in many immune-mediated pathologies, namely myasthenia gravis with acetylcholine receptor and MuSK antibodies, and that you work in identification of antibody-associated disease phenotypes, clinical response to treatments, and the outcome correlates. You have a special interest in understanding the interaction between pregnancy, antibody-mediated diseases, and treatments in order to improve patient care. And you're also curious about how autoimmunization occurs in patients and the biological relationship between autoimmune diseases that can occur in individuals, for instance, myasthenia gravis and neuromyelitis optica. That you have quite distinguished pathway through neuroimmunology, and you have an interest in diseases affecting older people, namely because of comorbidities that make diagnosis and treatment more challenging, and that you have an interest in immunosuppressive agents in older people and the complications associated with the declining of the immune system, and then just give you the floor. Is that all right?
Yes.
Okay, good.
The attendees are neurologists.
Well, they come from every walk of life. We don't have any selection process, so even patients can attend, although the webinars are a level that is not a layman talk, but everybody can attend. We have lots of physicians, lots of researchers, some patients, some relatives, and in fact we are now talking in our education board about starting to do some dedicated sessions for patients, for instance.
Absolutely.
To allow more participation of patients and to improve also the coverage that we get with these educational things.
It's very important to educate patients.
Yeah.
It's very, very important.
So it will take us probably 6 months or so, but hopefully in the second semester of 2021, we'll be doing already some patient driven and patient addressed seminars, because we have very good patient representatives and patient organizations that we are working with, and that will be possible.
Good. You don't have links to pharma companies, no?
No. On one side, our current agreement with the European Commission is very clear on that point, and they do not want any kind of links to industry.
I agree.
Which I understand and agree, and namely because they fund us, so to receive their funding, we need to comply with that. But the problem is that on one side, the funding is a bit limited. On the other side, the sustainability of the project is a bit not clear at the moment, so it's something that we discuss currently to see if we can do something about it. Of course, not in the sense, sorry, of providing a platform for industry to do marketing, but in the sense that they may contribute for certain and very clear actions with a transparent framework.
They could support some activities, yes.
Yeah.
It's a very difficult overlap sometimes of activities, but if you have clear rules, I think everyone can follow them.
Yeah, and clear rules are important. Exactly, and
follow them.
But at the moment, we still don't have any connection with industry.
Okay.
Nothing, so.
It's fine.
All right, so what time is it? Well, we are very near the time. Let's wait 2 more minutes. This is recording. All right. Hello, my name is Antonio Tavalia. I work for the Euro-NMD, the European Reference Network for Neuromuscular Disorders. This is one of our webinars. You by now know for sure the housekeeping rules, but as you know, during the webinar, you cannot speak, but you can talk with one another through the chat box, and you can use the Q&A tool to put questions in writing. In the end of the webinar, we'll be able either to read your questions, or preferably we unmute everybody and you can voice your question and we may have some dialogue. Apart from that, hopefully everything is going to schedule, and I have today the pleasure of having with me Professor Isabel Leite. She's an associate professor and honorary consultant with clinical and laboratory experiences in the field of autoantibody-mediated diseases of the nervous system, and she works in the Oxford University Hospitals and in the University of Oxford. Isabel has a particular interest in myasthenia gravis associated with acetylcholine receptor or MuSK antibodies, but also with other immune-mediated pathologies. Work includes identification of antibody-associated disease phenotypes, clinical response to treatments, and outcome correlates. She has a particular interest in understanding the interaction between pregnancy, antibody-mediated diseases, and treatments in order to improve patient care. She investigates how autoimmunization occurs in patients and the biological relationship between autoimmune diseases that can occur in individuals, for instance, myasthenia gravis and neuromyelitis optica. She has quite a distinguished pathway in neuroimmunology and an interest in older adults, namely because they are more difficult to diagnose and treat, and she has a keen interest in understanding the effect of immunosuppressive agents on older people and all the complications associated with the declining immune system of aging people. And so it is therefore an honor and a pleasure to give the floor to Dr. Leite and listen to her precious expertise on myasthenia gravis and learn about the most recent updates. Thank you, Isabel.
Thank you very much, Antonio, for the introduction. Thank you very much for the invitation by the European Reference Network. We belong to our center in Oxford, and thank you for all the attendees today. It's pity we don't see, I don't see them. I hope you can see me, and one day we'll meet again. So I chose this title of Challenges in Diagnosis and Management of Patients with Myasthenia, mainly because it's a day-to-day issue. It's not a difficulty, it's something that I embrace in diagnosing and treating patients with myasthenia. I can see 20 patients in one day, and they seem to me all different, and all have different problems, different challenges, and I feel the pleasure and feel rewarded by helping them to get better and have their problems minimized. So thank you very much again for attending. These are my disclosures. In addition to these, I'm a trustee of the MyAware, that is the Myasthenia Association for patients in UK, and I'm part of the medical board as well. It's not a disclosure or conflict of interest, but I think it's important, and it shows my interest in patient care. Myasthenia gravis is an autoimmune condition of neuromuscular junction, which can be shown here in a healthy way by some other authors. It's well recognized worldwide, has been diagnosed or recognized as an autoimmune disease many, many years ago, was probably one of the very first neuromuscular diseases, autoimmune, to be recognized or discovered many, many decades ago. It is associated with autoantibodies, mainly to the acetylcholine receptor or muscle-specific kinase. And here I show a diagram that then I hope you have access to the slides. You can see in more detail. On the left side, we have on the top the thymus, the bottom the bone marrow, and these two structures are very important, as well as all the cells of the immune system, important in the production of antibodies that eventually go to reach the nerve terminal and the neuromuscular junction to cause the damage of neuromuscular junction. And as you know already, certainly, at least many of you, only the thymus is only involved in the AChR antibody disease, not in the MuSK disease. But if in this part of the immune system and in the blood circulation, where the T and B cells eventually produce, are autoimmunized and produce antibodies, this is in common to every autoimmune disease, and eventually the plasmablasts produce antibodies that, with or without complement, cause the dysfunction of neuromuscular junction. With complement is the AChR antibodies, without complement, the MuSK antibodies, as you can see here. Now, if I show you now, the AChR antibodies are usually of IgG1 and IgG3 subclass. They activate complement, and the antibodies just approaching the neuromuscular junction activate complement. They have other mechanisms of action, but that is the most relevant, and they damage the neuromuscular junction. And these over the years can happen often, they yes and they no, and they can damage eventually the neuromuscular junction very dramatically until to be irreversible, the damage. So the sooner we diagnose and the sooner we treat, the better for the patients to not have irreversible deficits. So these are the AChR antibodies that activate complement, and there is a link between the thymus and this antibody production. Then the others are MuSK antibodies, which are of the IgG2 and IgG4 subclass, and they have no complement activation. They have a different mechanism of action, and they interfere with the clustering of the AChR, causing similar symptoms, as both have the same myasthenia symptoms or manifestations. It's a rare disease, but not one of the rarest diseases. It's rare, but not too rare, and has an incidence in different studies, have different incidences, but can go up to nearly or around 20 per million, but average is probably around 10 incidence. The AChR positive is slightly less, probably around 9 or so, but there are studies, different populations or different methods show different incidence rate, and the MuSK antibody is the less frequent, is very rare, and it has a different distribution in different geographic areas of the world. The prevalence rate is around 15 times the incidence rate. You can calculate more or less how many patients there are in each population or area or country. So the most interesting thing, and as many of you know, or if not all, is that the incidence rate of myasthenia has been increasing over the years. Every year increases by 3%, as you see in this graph here, done by my colleague Ashling Kerr. And so when I started doing medicine or neurology, you would see mainly young people. Now we see many more older populations with myasthenia. And there is an increase in incidence rate, as it is similarly an increase in the prevalence. Oops, sorry. So this shows again this graph that over the years, the early onset MG that is defined of the AChR antibody positive with the onset below the age of 50 remains more or less the same over the years, while the late onset MG, that is the myasthenia with AChR antibodies developed over the age of 50, has been increasing steadily over the years, around 7 times now more than 30 years ago. And if you want just a confirmation of that, you see that the bimodal distribution of the myasthenia in the old days was like this. So you have early onset, late onset, and in the middle, the thymoma-associated myasthenia was like this many years ago, and 20 years later, this is distribution again significantly higher in older populations, while the early onset and the thymoma patients or incidence remains the same. It's not exactly the same in males or females. This is a graph taken from a paper of Ashling Kerr, where you see in males this increase in the prevalence or incidence in the older populations affects mainly males, while the incidence in females is in both subgroups. And so is still in the females, you have still a bimodal distribution, while in males is more frequent in older older populations. Males are more frequently affected, which is strange. We don't know, we don't understand yet, and it's probably multifactorial, this phenomena. So just a very brief summary of the most typical weakness or distribution of the fatigable muscle weakness, which affect the ocular muscles with ptosis and double vision, facial, bulbar, or neck muscles, and the neck muscles are particularly effective in older people. So I showed this in one of my favorite pictures. The limbs and trunk can be affected, as well as the respiratory muscles. And so currently, our challenges in diagnosing and assessing or treating patients with myasthenia are related to the age. Older myasthenia patients, all of us in clinics, we see many more older people, adults. I'm not saying elderly, it's a variety of ages, but most of them over the age of 50. And the diversity of clinical and laboratory features, as well as severity, long-term immunosuppression, and adverse effects of that. Do not say that not all patients respond well or similarly to every single medication, and the increase in comorbidities, not only because they are older and they have other illnesses, but the medication, and particularly immunosuppressive treatment and steroid therapy, increase the risk of having other conditions, particularly diabetes, high blood pressure, and cardiovascular diseases, skin disease as well. So the clinical phenotypes and antibody status, usually we start by how the patient presents, what are the most common symptoms, and usually we divide them in ocular. They started with ocular myasthenia or generalized myasthenia, and the majority of patients start with ocular manifestations, which may remain only ocular, and in 10–25% of patients, but the great majority of them, therefore, become generalized within the 2 first years of disease, together with 40% of patients who start with generalized symptoms is a great majority of patients who we treat when we diagnose them, or within 2 years of the diagnosis, they have generalized disease. And these ones, those who quickly become generalized, are those with AChR antibodies, those with thymoma, and those who haven't had yet any immune treatment. Then we can divide them according to the antibody status. Majority of people have AChR antibodies. Majority of them, in fact, in generalized myasthenia, 50% of those who start with ocular myasthenia, and around 20% have no AChR antibodies. But fortunately, with more studies over the years, we're able to identify all of us, MuSK antibody patients, MuSK antibodies in patients with generalized myasthenia mainly, 1/3 of them, depending on the geographic area. For example, in the Mediterranean areas compared to Northern European countries, they have more MuSK myasthenia. Some of them have antibodies that are not detectable by the standard assays, and they have antibodies to the AChR, but only detectable by the cluster AChRs, which were developed here in Oxford. And only a small proportion of the patients have negative, seronegative myasthenia, which I personally see very few of them. We eventually diagnose them either with a different condition, or eventually the antibodies become more easily detectable. So usually we currently classify the disease according to the autoantibody target, AChR, and with that generalized or ocular, with early onset, late onset, or with thymoma. Some of them have AChR antibodies, but detected only by a more sensitive assay. They have patients, a smaller proportion of patients with MuSK antibodies with non-complementing activating IgG subclass, IgG4, where the thymus is not involved, and therefore no thymectomy is required. And now there is a smaller proportion of patients with LRP4 antibodies, where the thymus involvement is not yet well established. And say from my experience, I see very few with LRP4, and most of them are either associated with AChR or MuSK antibodies. It's still ongoing work. How do we manage myasthenia? There have been many guidelines over the years on how to best treat patients. And I'm just giving an example of guidelines who are prepared for doctors, neurologists who do not deal with many patients with myasthenia. And this is mainly directed to patients with AChR antibodies. Because MuSK antibody disease is rarer, we pay and we prepare the guidelines for the AChR antibody disease. And the main difference to MuSK antibody management is not doing the thymectomy, and probably another choice in the treatment, immune treatment, which I will say about that later. So if we diagnose a patient with AChR, with myasthenia, with AChR antibody serology and neurophysiology, you next categorize them clinically. If they have no antibodies or no neurophysiology to confirm that, I think we all agree that it's important to consider myasthenia mimics, think about congenital myasthenia, or refer the patient to a myasthenia center to more carefully be assessed, instead of starting the treatment without certainty in the diagnosis. So if they have generalized myasthenia, they can be more severe or less, so mild or moderate, or they may have only ocular myasthenia. And the next step is checking whether the patient has a thymoma. This, we are talking about AChR antibody disease. If you do the scan, if they have a thymoma, they have an indication for thymectomy, and that then is assessed whether the patient, regarding to the age and the other health problems or not, is, and depending on the size of thymoma, etc., will have a thymectomy, but has theoretically a very straightforward indication for thymectomy. But if the patient has no thymoma and have AChR antibodies, and they are younger than, I would say, 50 years old, but because of thymectomy trial goes up to the patient, included patients up to 65, there is a gray area between 50, 55 or 60 or so, where you can consider thymectomy depending on the patient's general health and the choice of the patient. So you can assess that and discuss with patient doing thymectomy, because it's certainly in younger people that helps in the management and improve the disease. Then if the patient has, if we go up on the left side were the most severe patients, if you go back to there, that most severe patient after diagnosed has to be likely to be, it needs probably to be admitted. The first treatment you think about if a patient is severely affected is start with steroid therapy, escalate to treatment, IVIG or plasma exchange, optimize periodostic mean if they respond to periodostic mean, and try to improve them. You can start discussing and considering immunosuppression to add to the steroid therapy to reduce the risk of long-term side effects of prednisone, but it can be discussed at a later stage if you want or the patient prefers. If the symptoms are moderate, milder or ocular, you may start only with periodostic mean. And then depending on the response, if I have poor response, you might go to prednisone, or if good response, continue on that treatment. But pay attention that the thymectomy needs to be within this time. The sooner thymectomy is done, the better. But the patient needs to be well controlled. The myasthenia needs to be well controlled to go through a surgery. So no rush, but keep that in mind and prepare the patient for thymectomy and for a long-term immunosuppression or steroid treatment or other treatment, because this is a chronic illness. Escalate the treatment depending on the response and the severity of disease. You can titrate periodostic mean to the lowest effective dose, but sometimes it's not enough, even in ocular. And although sometimes we think ocular myasthenia is a mild disease, but can be functionally affecting the patient enormously. You may, when you improve the patient, if it is a mild, moderate disease, keep them on a safe long-term lowest possible prednisone dose that you can reach without side effects. Although it can be difficult, each patient responds differently to steroids in terms of side effects. Majority of patients have benefits, but they suffer with side effects, and therefore thinking about immunosuppression from early on in some patients is quite helpful. But we need also to think about long-term potential complications of immunosuppression. Nothing sounds easy, and so we need to think about each patient and what treatment is the best for that particular patient. Take into account everything: the age, the gender, the comorbidities, their job, the family, etc. All of that counts. And so there is no right or wrong treatment. Has to be overall safe, beneficial, and acceptable for the patient overall as an individual. So if we end up with a very severe myasthenia that doesn't respond well to immunosuppression, I think in the past we didn't have access to many immunosuppressive agents or the new immunotherapies, and we ended up with patients on year after year after year with many drugs, different drugs, steroids, and then try azathioprine, then try methotrexate, try cyclosporine, mycophenolate, and we end up with patients on multiple immunosuppressive drugs with no very good control of myasthenia, because disease can be quite difficult, but also with consequences of these long-term immunosuppressive medication. These now, thankfully, now we start having access to other medications, and my advice is to start thinking about them quite early on. If I now have just some brackets to say about thymectomy, to remind people that there was the randomized trial for thymectomy in myasthenia for those without thymoma with ACH antibodies, and that clearly showed that thymectomy with the prednisone is superior in benefit for patients, superior to prednisone alone, not only because their clinical improvement was better, so the score, the highest, the poorer, and is better when thymectomy was done in association with prednisone than the prednisone alone. And when the patients were able to reduce prednisone as the clinical picture or features improved, they managed to come down in the prednisone dose significantly, or this dose was lower than in those only on prednisone. So the thymectomy showed benefit in comparison with prednisone alone. But in addition, showed also superiority in other aspects, that fewer patients needed azathioprine, which could have been associated. Hospitalizations were much lower than in patients only on prednisone, so not so many exacerbations. MG-ADL, that is the functional score given by the patients, was lower in those that were thymectomized, and there were higher percentage of patients that were able to withdraw the prednisone. And so when they finished the trial, they were off prednisone and they had only minimal manifestations. Overall, the trial seemed to be more effective in younger people, but the older people that were included in the trial were a smaller number, so it's more difficult to be absolutely certain, but there is, if needed, there is some background information to support the thymectomy in those over the age of 40 and certainly 50, and if not more. So what are, to me, the treatment challenges? The first ones is the relevant side effects, some of them irreversible. Steroid therapy causes multi-system problems, often silent for many years, and sometimes patients only after 30 years, 40 years start having the diabetes, the high blood pressure, skin problems, the cardiovascular disease, infarcts, etc. This is scary to many people, do not say about increased weight, osteoporosis, glaucoma, etc. Some risk of infections, not massive. Some risk of malignancies, particularly in those on immunosuppression, particularly azathioprine. I'll give you a couple of examples of that. Refractory disease, this is another challenge. It's very difficult to treat some patients that have like a treatment-resistant disease. As in any disease, there are patients who respond better than others, who have a more complex disease. This affects 10 to 30% of patients, depending on the studies. and is refractory at any age with any type of disease, either ocular or bulbar or generalized, affecting limbs or other muscles, these patients are exposed to a number of different immune treatments over the years, and many of them start when they are very young and could be on their teens, and they can be on immunosuppression for 20, 30, 40 years or more. And this has consequences. They can be admitted frequently, and they may end up with irreversible deficits related to myasthenia, because eventually the neuromuscular junction damage doesn't recover. And above all, it's important that we recognize that these patients can have poor quality of life because the disease, because the treatments, and the overall process of having a chronic illness that requires so much treatment. Fortunately, not all of them are so difficult to treat. But there are new treatments, and I brought up this diagram again, where we start saying about against the new treatments against B cells and downstream effects. So one of the first treatments that started being used in myasthenia more recently was rituximab, one of the anti-CD20 or B cell targets. And you find the CD20 cells, like the memory B cells here, and other short-lived plasmablasts, and some other B cells here. And they think that by killing the B cells, this may help then do not allow plasma cells to develop and then produce the antibodies, and eventually prevent the antibodies of reaching the neuromuscular junction, and then of causing damage by complement activation. So these are the drugs anti-CD20. There are others that are now being developed and being tested in patients with myasthenia that are anti-complement. So the antibodies are there, but complement cannot be activated. And there are some drugs which are more toxic, but in extreme cases have been used in myasthenia patients, that proteasome inhibitors, and those are to inactivate the plasma cells. And then also, finally, the anti-Fc receptor medications, which are going to degrade the antibodies. So we start having, hopefully, access to a number of different treatments, which we should use cautiously, because no medications are free of potential side effects and the complications, but it's good to have them to help in patients who may not respond to other treatments or may choose to have them early on if they are accessible and not very expensive. So anti-CD20 for the B cells, proteasome inhibitor, I suggest only in very rare cases for plasma cells, and the Fc receptor to reduce the antibodies, and anti-complement to prevent the complement activation and damage of the neuromuscular junction. To remind all of us, only the AChR the anti-complement medication is appropriate to treat AChR antibody myasthenia, but not MuSK antibody myasthenia, while the other three can be used in MuSK myasthenia patients. So what we want in the end is that do not have any damage or dysfunction of neuromuscular junction, regardless the drug that we are going to use and the mechanisms they work through. So these are the B cell depletion, the rituximab or anti-CD20 cells, anti-CD20 cells or B cells. They are very usually are used in very severe myasthenia, in refractory treatment-resistant myasthenia. That's where they have been used until recently, it has been proved to be beneficial in myasthenia in uncontrolled studies in all myasthenia subgroups, but particularly in MuSK antibody myasthenia. And this is really important. Even MuSK myasthenia is not very frequent, but is often difficult to treat with other immunosuppressive drugs, and some patients have early on a muscle atrophy, and so having a medication that is known to be beneficial to them, and if the price of the rituximab comes down or generic generic drugs are available, is a good choice for MuSK antibody disease. We know that there are cases, very rare cases of PML in patients with rituximab, very few in patients with myasthenia, and all of them have been initially or prior to the rituximab on previously on other immunosuppressive drugs. And so I thought that the earlier we give, probably the safest it is, although there is no enough data to show that evidence. In PML, the PML in rheumatological disease has been shown to be less than 1 in 30,000 patients. Again, has been used in patients on chronic immunosuppression where their bone marrow has been already subject to damage by other immunosuppressive drugs. So in retrospective studies show that, in fact, if you treat AChR antibody disease on MuSK, and more patients have been treated with AChR antibodies than with MuSK, you see the post-intervention status with minimal manifestations or better means in remission. You have 30% of patients with AChR antibodies that can achieve that status, that is good. But 72% of MuSK antibody patients that were treated with rituximab achieved that status, which is very significant. And post-treatment relapse is reduced in AChR antibody disease, but much reduced in MuSK antibody disease. And we have experience also giving rituximab to MuSK patients. And sometimes you give 1 cycle, 2 infusions, and they are well for several years. And that is quite good news. The antibody levels sometimes decrease after the treatment, and it has been shown that it decreases mainly in MuSK antibody disease rather than in AChR antibody disease. So that was a study that couldn't show a strong response to a rituximab. It was then in refractory generalized AChR antibody myasthenia, didn't reach the endpoint, but it was safe and well tolerated. And in my view, and probably of many people, this is because the rituximab was given only to AChR antibody patients and was given to those with refractory disease, already with disease for many years, and therefore the cells that were targeted were probably not those that were actively producing the antibodies, and this patient had already probably only plasma cells producing the antibodies. Second line in any moderate and severe disease seems to be now we should aim to give them the moment we see that they don't respond to the first line therapy, to even moderate severe disease. And the Scandinavian countries, they are trying to give even as a first line therapy, which if we have the ability to do so, is probably helpful. What we don't know yet, and we have to be cautious, is the long-term potential risks, complications of rituximab very early on in disease. It's difficult, and I hope within a few years we'll have answers to these questions. Seems to be sensible to treat as early as possible, to the best medications we have, suitable and accessible, and if not very expensive, but we need to pay attention to future future complications, which we don't know yet well. This is being considered also for early treatment in mask myasthenia, knowing the so good response to this treatment, to rituximab of mask myasthenia. So in England, we have access to rituximab treatment, but only in certain circumstances, not in as first line. It's only in patients with ACH antibody disease, generalized disease, that do not respond to other treatments or have a very severe disease, or have very serious potential complications of steroid or immunosuppression, or have an explosive disease onset. But we have a lower threshold to treat mask patients with rituximab, which is good. Complement inhibitors are being tried. Eculizumab is one of them, has been shown to have a modest efficacy in patients with AChR antibody disease. And again, I think the not so high or better improvement response was the refractory characteristics of the disease in these patients. And so probably not so easy to improve when the muscles are already atrophic. Eculizumab is being approved but in several countries, and although it's approved by EMA, hasn't been yet approved by NICE in UK, and so we cannot use it yet. It's a high price, it's very high, its mechanisms of actions limits it to AChR antibody disease, which is okay. It needs probably concomitant or follow-on immunosuppression, because it's very difficult to keep a patient for life on eculizumab, and we don't know yet if we stop the eculizumab treatment or anti-complement treatment, whether the effect will remain for very long or not. It may not be suitable as long-term therapy, not a very useful agent in late stages of disease, again, if we have a very irreversible damage of neuromuscular junction. Whether it's useful during a severe myasthenic crisis is another question. It may bring risks of infections, is something that's still open for discussion. There are other treatments being tried. Zilucoplan is another complement inhibitor in phase 3, which seems to be going well. Bortezomib, that is an is a proteasome inhibitor for plasma cells, and two others, the anti-FC receptors, being now also in trial phase 3. We don't need to go through all these. I'd say that my treatment challenges, the next ones are the side effects of steroids and immunosuppression. Many times, many drugs have been tried in a row. Side effects of new treatments, we don't know yet all of them, but rituximab can lead to low immunoglobulin levels, low T and B cell lymphocyte count. However, if we treat patients early on with rituximab, we may not have such potential complications, especially if we can manage the patients with lower doses than that is usually in protocols. And severe infections is something we need to pay attention to. So one of other point is unknown potential long-term complications that we require more years to know about them, but many people have been using these in other conditions, and I hope we learn from them. One thing is important for us is to rethink explanations for poor treatment response. We think always whether there is something else in addition to the myasthenia that is contributing to poor response to treatment. And I just have on top of my head the obstructive sleep apnea. Patients sometimes complain about general fatigue, tired all the time, And it's always helpful to think about any other factor. Could be sleep or obstructive sleep apnea, can be anemia, can be many other conditions, cancer or other problems that can contribute to that. Think about refractory disease, can be 10-30% of patients, unexpected thymomas or other malignancies later in the disease course. Differential diagnosis in seronegative myasthenia is always helpful to look at and burnt out condition. And think always to optimize standard treatment is important. And if the response to the standard treatment is not good, early on, you have a good window to think about new treatments, to plan those and give new treatments if possible. And if while they are not available, try to do in trials, because very late, it may be too late and not helpful. I don't have a watch with me. I don't know how is the time, Antonio. Could you please tell me? I'm okay with time. I can't hear you. You are mute.
Sorry, you have 5 minutes more. You're on 45 minutes. Okay,
thank you very much. So I wanted to remind everyone about thymomas. They are found in 15% of patients with ACH antibody disease, mostly generalized and ocular. It's important that they can appear as or present as myasthenia, but also as opportunistic infections, alopecia, or other manifestations, such as weight loss. And thymomas require careful monitoring, clinical and radiological. We should always think thymoma can be a thymic malignancy. And it's important because not all thymomas are the same. And think about histology. Always try to understand and to learn from these. So the prognosis of and risk of recurrence of a thymoma depends on histology from top to down. And I have here a couple of cases, and you wonder whether, for example, if a patient had early onset myasthenia and they had thymectomy, could they develop a thymoma anytime? And I'd say, yes, they can. It's very rare. I have the example here of a patient when she was 30 years old, she had myasthenia, was thymectomized in Japan, and was well for a while, was in remission, and 8 years later, the myasthenia got worse. She had several admissions. ACH antibodies went up. She needed IVIG plasma exchange several times. And when we rescanned her, she had a thymoma in the thoracic inlet. It had a thymoma in the thoracic inlet. It was a B2 thymoma. So it's not impossible to have a thymoma after you remove the thymus. 24 months later, she was very well, and she has been well since then. How long should we monitor the recurrence for or look for recurrences or metastases? I will just go through this quickly, and then I hope, Antonio, that the slides can be available to people. And by the end, I have also my email address, and so people can ask questions. But I'll just highlight here that even this is a patient who had a thymoma in 2002, aged 31, and was well, had thymectomy, was scanned, had a B3 thymoma, which is a well-differentiated thymic carcinoma, and was thymectomized until 2010. In 2010, she was well for 8 years, and myasthenia recurred very briefly, and we scanned that again, and she had 2 lesions, and the mediastinal and diaphragmatic lesion, both were removed and were at the same thymoma. We can also find them later on when the diagnosis is done later, and I'm going just quickly, just to highlight that a recurrent thymoma can come many years later. here an example of a lady that had thymectomy, radiotherapy, and 10 years later had, or longer than that, the mediastinal recurrence and the liver metastasis, which is very rare, a B2 thymoma. And finally, a lady who had late onset myasthenia, had no thymoma, and in remission for 16 years, only on a low dose of azathioprine, and presented with more myasthenia symptoms, but more so with the dysphagia that was retrosternal, had weight loss of 2 stones, and had candidiasis of the esophagus. And she had Campylobacter jejuni infection as well. And this made us think she could have a thymoma, which she had. And it was quite sad that it was already disseminated and it was inoperable and was fatal. If that is okay, and because the time limit, I will stop here. I had another case, 2 more cases, but I think we can, if there are not many questions, then we can go through these 2. If there are questions, of course, I'll answer to them, and then the attendees will have the slides and they can go through them. What I wanted to do in the end is to have this message in the end, that is, thymoma histology is relevant. They may occur many years after its removal. Radiological monitoring is necessary over the years, probably for life. Early detection and treatment of thymoma prevents recurrence. And worsening of myasthenia symptoms with stable disease for years is important. To pay attention to the presence of opportunistic infections, reconsider thymoma, even if patient had a normal CT first, and consider other malignancies of the head or neck, because not all myasthenia symptoms are always myasthenia, caused by myasthenia, but could be caused by other conditions. And so I'll leave now here, and I will just, leave this. I'm so sorry for the time.
No, that's perfect. Thank you very much. And yes, the recording of this webinar will be available through the Euro-NMD website. And so you can all revisit the recording, and we can also have some people who didn't attend watch the webinar. If you want also to give your slides for download, we can do that as well. So that's not a problem.
Because I didn't go through the last slides as it should be, I would prefer the slides to be also available as a PDF.
Okay, that's perfectly possible, no problem. We have a few questions. One is about ambulonium, but I'm not sure if you have any experience with it instead of pyridostigmine.
Which is
it's an inhibitor of the acetylcholinesterase that exists in France, but I know that it doesn't exist in the UK. So you don't have experience. Okay. Right. The other question was Teresinha Evangelista asking which is your preferred first-line immunosuppressant.
Okay, it depends of the age of the patient, gender, and possibly other conditions. Nowadays, if I have an adult that, so female, after the childbearing age, or a man, I would go for mycophenolate.
Okay.
It's easier to start, is better tolerated. If I have a young woman that probably wants to get pregnant, I go for azathioprine. Then there are small small things to take into account in other subgroups, but these two would be the major ones.
So Jose Wongatu asks, the incidence of MG is increasing yearly by 3% in the older population. You said that early treatment brings the best outcome. Are there any signs of MG that can be identified earlier on, even before onset?
I don't think so. It's very difficult to diagnose myasthenia early on. For example, if you have a thymoma only, patients with thymoma, 1/3 of them will have ACH antibodies and they may develop myasthenia. But apart from removing thymoma, I don't think we can start the treatment without the illness being clinically evident, because all the treatments can have side effects and patient may not develop the myasthenia. What I probably say is that those with very mild ocular myasthenia, try to discuss with them whether they wanted to start some treatment, and particularly consider thymectomy even before they generalize, because it may prevent developing a generalized myasthenia. Again, there are many studies on that. It's difficult to prevent an illness before it is clearly clinically evident.
Okay, Leila Badisal has a case of thymoma that was operated and treated with radio, and 3 years after that, the patient developed myasthenia, severe form. There was no evidence of recurrence or metastasis from the thymoma. Have you heard of such case as this?
Yes, it can happen. After the thymoma is removed, or the thymectomy doesn't completely remove the possibility of developing the autoimmune disease after, because the autoimmunization happened while the thymoma was there, and so then you have B cells prompt to produce antibodies. And it's possible that that patient had antibodies before, so developed myasthenia later, despite of having no thymoma. The same happens with the myasthenia. If you have myasthenia with thymoma, you remove thymoma, but still the patient remains with antibodies and requires treatment. So yes, it's rare, but it happens.
Okay, we are going to have just one more question. We have lots of questions in line, but unfortunately no time. So the last question will be about hematopoietic stem cell transplantation from Jean-Thomas Vilquin. Is it efficient?
That's a good question. And there have been very few cases where that was done. I think has been done in very severe cases because the risks associated with the transplantation. I don't have all the data with me to be able to answer in more detail, but I think would be the last resource. I thought I'd go first for the new treatments that we have available.
Okay.
Available.
So, Isabel, very much thank you. I think this was very interesting, and the number of questions and participation was a testimony of that. And thank you very much for your help and for sharing your expertise. I'm sure that we'll meet very soon. Okay?
Thank you very much.
Bye
Thank
now.
you to all the attendees, and I'll be happy to answer other questions at a different time.
Okay.
To share